There's been a lot of controversy, as you know, about whether we should have targets for LDL reduction. And if you look at the current guidelines in Europe, Canada, and the United States, they're actually quite different. In Europe right now, there's a strong recommendation to have a fixed target of a certain level, or, and that's the critical thing, or a 50% reduction in LDL cholesterol. Now in Canada, they've done the exact same thing. The current guidelines say try to get down to a certain fixed target, like less than 100 or less than 70, or achieve a 50% reduction in LDL cholesterol. Now that may sound unusual to a US audience, but in fact the ACC-AHA new guidelines, where people say we got rid of targets, actually didn't really get rid of targets because they also talk about using either a moderate intensity statin, that's by definition a statin that lowers 30 to 50%, or a high intensity statin, a statin that lowers LDL cholesterol by 50% or more. So all three of these guidelines have in them the concept of percent reduction. But there's very little data about percent reduction. So we actually took a look at our Jupiter trial, which was a primary prevention trial of relatively low-risk individuals, and then asked the question, what's the relationship between the percent reduction in LDL cholesterol and the outcomes in the trial? And the data are really quite surprising. If you can imagine for a second a graph, and along the x-axis is 7,000 individual people lined up in order of their percent LDL reduction when they got a powerful statin, rosuvastatin 20 milligrams. Now some of these individuals had no LDL reduction at all. Perhaps they were non-compliant. There's a large group that then got 10, 15, 20, 25% LDL reductions, and another large group that got 50, 55, 60, 70, 85, and 90% LDL reductions. Well, as it turns out, even though we say it's a high-intensity statin that averages a 50% reduction, those differences tracked exactly with the event rates. So the highest event rates was the placebo group, the next highest the group that did not get a percent reduction, and then those with a 0 to 50% reduction had a drop, and the greatest drop were those who had the largest reductions. Well, why is that important? It's actually very important in thinking about where guidelines might go. Because if we say to our primary care colleagues and our general internal medicine colleagues, it's not so much reaching a fixed target, say less than 100 or less than 70, but it's getting your cholesterol down by 50% or more, then we have a much different playing field for new drugs. If you're in that group that's on a high-intensity statin and lowers your cholesterol by 70 or 80%, there's not much room to go. And your residual risk might well be on the basis of inflammation instead of on the basis of cholesterol. But if you're in that group that on a high-intensity statin only has a 20, 25% reduction in LDL, you might well want to go to another LDL-lowering drug, like a PCSK9 inhibitor. So part of the issue being raised in these data is, do we want to be moving percent reduction LDL to a more prominent role in our guidelines, and then start asking the questions, when new agents come along, like PCSK9 inhibitors, is a rational way of using them to think about, maybe I won't use that drug when the percent reduction is already down 80 or 90% because there's nowhere to go, but I would use it when the percent reduction is only 20 or 30%. So these data are going to raise a lot of interesting issues about guidelines, how we think about preventive care, and where we're probably moving in the future. I think the message here is that we can't treat drugs as working the same in all people. Now we all know that, but our guidelines are suggesting to us, if you're in a certain risk group, take a high-intensity statin. I actually completely agree, but you're going to need to know what percent reduction did my patient get, because that individual patient I'm responsible for might need more LDL reduction, but they might not, and they're all getting the same drug. The second piece is we have to think more broadly about what's driving this disease. Residual risk we think of now as cholesterol residual risk, but a big piece of this puzzle is inflammation residual risk. And if the inflammation lowering trials also show efficacy, and I hope they will, then we're going to have to select a LDL lowering drug or an inflammation lowering drug. This is the essence of personalized medicine, trying to get us to think about what does the actual patient have as their problem driving atherosclerosis, and then picking a biology, if you like, that leads us to a certain type of drug. That should be the future.